Good morning. My name is Bashir Towley. I'm a radiologist here at Mount Sinai. Interested in body imaging and cancer imaging. So it's a pleasure for me to introduce the speaker for this session, for the cancer imaging session, Dr. Anwar Padhani, who is a professor of radiology and cancer imaging. He's a pioneer. He's one of the early adopting the functional MRI methods in cancer. So he's been doing really a lot of pioneering work on DC MRI, and more recently, and also on oxygen imaging, and also more recently on diffusion. And he wrote a very large number of papers, scientific papers, textbooks, and he's also, internationally known. Gave a lot of conferences, and he works actually in the cancer center, Mount Vernon Cancer Center near London. And it's really a pleasure to have him here. He's going to talk to us about his recent experience using whole body diffusion imaging in cancer patients. Anwar.
Good morning, everybody. Thank you, Bashir, for that kind introduction. I actually wrote the introduction, by the way. Bashir got me into this subject because one of the things he said to me about 3 years ago, he said, Anwar, you chaired the consensus meeting on diffusion imaging, yet you've never ever written a paper on diffusion imaging. How can that be, right? And so I thought, well, I can't do liver because Bashir's doing it. I can't do the kidney because somebody else was doing it. I can't do the prostate because somebody else was doing it. So I said, okay, I'll just pick the most difficult organ there is, and that's the bone marrow, and see if I can figure that one out. Now, so to give you a perspective, all of you will have seen headlines like this. The press is just full of them. There are advances in molecular medicine, and we see patients living longer, particularly in prostate cancer. But you also find headlines like that one on the right, where the regulator says, I'm not going to pay for this stuff. So in the UK, we have this organization called NICE, the National Institute of Clinical Excellence, that decides whether they're going to pay for these new drugs. And basically they say, this doesn't meet a quality endpoint, and we're not going to pay for this. And this is a common problem, particularly in Europe. So what's the problem? The problem is that complete and durable responses still tend to be quite rare. So, for example, if you look at most new cancer drugs, it only works in about 30% of people that actually receive it. So 70% get no benefit, yet you spend hundreds of thousands of dollars treating these patients. And overall survival remains poor. We know that these drugs are not innocuous. And we talk about targeted therapies having no side effects. But when people drive I had a patient last week who drove into a tree, simply because he was on a new drug and it caused him to have a fit. So they are not innocuous. And the problem is the patient space is getting very tight. So look at this. This is prostate cancer. If you develop metastatic disease, to the time you die is 3 years on average. Okay? Now, what have we got? We have got, looks like about 8 drugs over here. 8 drugs. This is the only one that's not licensed, and it'll probably get licensed next year. So you need to fit in these 8 therapies into a patient. One of these may work with a 30% response rate. One of these may work. How do you know which one you're going to use? Which one do you give first? What? Second, third line. And and the drug companies are all hassling in this space. And actually, this is a real challenge for clinicians. When we had 2 drugs, it was easy. Now we've got 8 drugs, it's a problem. Predictive biomarkers are not available, so I don't know whether a particular drug's going to work. And the final problem is that common methods of assessing response don't work very well. For example, in the prostate, let's stick to the prostate theme today. What do we have today to assess response? We have the serum PSA test, which is prostate specific and not cancer specific. We have markers of bone turnover. So we look at the bone rather than the tumor, right? The effect of the tumor on the bone rather than the tumor itself. We ask patients how they feel. We ask them about pain. We ask them if they've broken a bone. That's how we are treating patients today. And you guys are scientists. You don't realize what's happening in the hospital next door. This is exactly what's happening. So we can't prospectively predict who is going to respond. We can't predict who is responding early after starting therapy. So look at this. This patient has metastatic prostate cancer. This is just some imaging. We've got the bone scan on the left. We've got T1 and T2 images. We've got a whole body diffusion scan. We've got axial T1s, T2s. But I can't use any of these modalities and predict whether this patient is going to respond. I just can't do it. And I'll show you that this patient does in fact respond in a few minutes. Now, because we can't predict who is responding early on after starting therapy, what we tend to do in the clinic is to treat until something bad happens. Until something bad happens. So this is called treating to progression. And this happens in the clinic, and this happens in clinical trials. Right? And the consequence of that paradigm is that you get exposure to drugs that don't work. Right? So you treat, and suddenly you break a bone and you think, that didn't work, I'll change. And then you treat, and you treat, and you treat, and then you break another bone. And then you say, that didn't work. That's how it works. So by the time you get, if you go along this pathway, you've been exposed to 3 drugs and then you're dead. Right? It's too late. So you may not get exposure to an efficacious medication. And I'll show you that this is actually what happens. Now, here is a patient, right? Bone scans is the standard of care to look. So look over here. After 13 weeks of over 12 weeks of treatment, so in the 13th week, we have 3 new lesions. Is this response or is this progression? Now, all of you will say this is progression, correct? And in fact, you are wrong. In fact, you're right and you're wrong, and I'll tell you why in a second. Okay, but look what happens. We have to wait, because if we use consensus criteria, these criteria that were developed, the prostate cancer working group 2 criteria, it says that you have to repeat the scan more than 6 weeks later, and you have to demonstrate more than 2 lesions. So you can see this is another 12 weeks later, not 6 weeks, another 12 weeks later, 3 months. Oops, the patient is worse. Did that make any sense to you? So you had exposure to a medication for 3 months that you did not benefit from. And this is the crazy situation. Now, why is this criteria exist? Well, look at this patient. This patient, 3 months of exposure, you'll see new lesions. You can see the red arrows. Now, look at this patient. You can see they kept on treating. And look what happens over time. So over time, you see that, in fact, this patient did respond. You see, they carried on the medication, and you can see that over time the patient improved. So what does that tell you? That tells you that there was a flare response. It's quite well known. The flare response looks worse, but actually is better. And this is a problem for clinicians. The flare response occurs in about 30% of cases. Now, can we make the bone scan better to try to get over this? And there are a number of new technologies that are coming along. I've just listed them over here, which may be helpful. But I can't see that happening fundamentally. So what's the issue? The issue is that the cancer cells are in the middle of the bone, in the marrow space. And what are we doing? We are looking at these osteoblasts, which are the lining cells of bone marrow, right? So does that make any sense to you? You're looking at these cells over here and expecting to know what's happening in the middle here. It just doesn't make any sense. That's why it doesn't work. What we should be doing is doing something else, right? And I've just put up a few technologies up there that you could potentially use to try to further improve the diagnostic process. So you could use a number of PET techniques. You can start to look at the bone itself. You can look at the vascularization of tumors, or you can look at the fat and the water within the marrow space, and the tumor cells themselves. And that's what we're here to talk to you about today. Now, it's very clear that, in fact, no one modality will cut it. And it doesn't make any sense, right? You have a complex organ. You can't expect to use one modality to sort out what's happening. You are going to have to use a number of modalities. And that applies to imaging as much as anything else. So what about CT scans? Now, CT scans, of course, looking at the bone. And we know that there are response criteria that do correlate with outcomes in patients. So in other words, if you have a metastasis that becomes sclerosed and becomes dense, clinically we know that's a good sign. We know that that means that the patient is probably responding because it's healing up, but that's not always the case. So for example, look at this patient over here. You can see this lesion here is barely perceptible, but after a few months you can see it becomes densely sclerotic. Similarly, look at this metastasis. You can see it's just eating away the bone before starting treatment. Afterwards, you can see a trabecular bone, organized bone, beginning to be laid down. That's a good sign, okay? But the problem is that looking at this feature is an issue, particularly if you are using anti-osteoclastic medication. So patients get anti-osteoclastic medications to try to strengthen the bone, to stop the tumors eating the bone away. And there are a number of these patients, there are a number of these drugs available that are routinely used in the clinic. So the thing that can happen is you can get worse and you can still become ossified, right? So you can get worse and you can still ossify. So the technique does not work that well if you are on an anti-osteoclastic medication. And the fact of the matter is the vast majority of patients are on these medications. So you can shoot yourself in the foot by using this technique. So not a great technique, but people use it. It seems to work a little bit. What about PET techniques? Now, provided your tumor is PET avid, in this particular instance FDG, then the change can indicate that you are responding to treatment. So it seems reasonable to think about that. So, there are very few traces that are available in the clinic to use. FDG PET is the one most common. There are other traces that are on the cusp of being used, such as sodium fluoride PET, which is just a super bone scan with the same problems as bone scans. But you could use, for example, FES, for example, fluoroestradiol for ER-positive patients, for example. Now, FDG can be useful if you are hot to start with. But if you have a sclerotic metastasis, prostate cancer, breast cancer, the two biggest killers, FDG isn't that good, in fact. And in fact, you can find that you can get flare responses. In other words, what happens is sometimes with some medications, the FDG actually increases. And that increase, i.e. getting worse, actually predicts that the patient's going to get better. So paradoxically, instead of it going down, it could go up. So again, this is this flare response, which we talked about in bone scan, that can occur with some medications, and that can usually be seen with, particularly in ER-positive patients. So potentially there's an issue there. Now, I'm going to be talking to you about MRI techniques, and I've just put up a few techniques that you could do all of these techniques in the clinic today. So this is something you could do today. And because MRI is a multimodality workhorse, you could combine that to develop a multimodal assessment of tumor. And I just want to demonstrate that to you now. So a whole body MRI protocol is actually very simple to do. It takes less than an hour. It consists of anatomical images through the spine, for example, T1 and T2 weighted images, which is what radiologists like to use to look at the anatomy. But you can also get functional information and incorporate this routinely into the clinic. So you can get a 2-point and a 3-point fat fraction of the whole body. You can do diffusion weighted images. From that, you can work out an ADC map, and the ADC map tells you something about the diffusivity of the water in the bone marrow. And in fact, you can use these progression criteria or response criteria similar to this to try to predict what's happening in the bone marrow. And that works reasonably well. The problem is this. So here is a patient that's actually improving with treatment, and I'll prove that to you in a second. I mean, she's improved because she's alive a year later. That's one hint. But if you look what happens early on between August and November in this particular patient, she looks like she's worse. Right? You see that darker signal in the bone marrow. So if you look over here at this particular bone, it becomes darker. So this is actually a pseudo-progression. So it's just like a flare response that we were talking about. You sometimes get increasing darkness on a T1 sequence, which is just water. It's just water coming into the bone marrow, which then subsequently leaves. And you can see that. The medication just carried on, and you can see that the patient improved. The other thing you'll see here is the fact that this patient broke this bone, for example. Right? That bone broke. Now, traditionally, the breakage of a bone, it means the patient is getting worse. But actually, in this particular instance, the patient is getting better. So, because what happens is you take away the tumor, and there's nothing left, right? And then the patient collapses. And you'll see these multiple fractures in patients as they get better. So they come to your clinic and they're all hunched up because the bone, the tumor that was holding the patient up is gone. Right? So that traditional endpoint of a fracture, which was patient is worse, in this particular instance, it means the patient is better. So even morphology has a problem. Now, what I want to show you is something called diffusion imaging. Now, you heard about diffusion imaging in the last lecture, but in this particular instance, we are going to use diffusion imaging as a method of looking at cell kill. In other words, it's about death. So let's talk about cell death. Now, here's the same patient that I showed you. So this is this same patient, okay? Now, you'll notice that the signal intensity on a high B-value image reduces on this whole body MRI scan. Now, look what happens to the histogram. So that is the histogram prior, and that's the histogram at this particular time point. So can you see how it shifted across? Now, that you can equate to cell kill. As you kill cells, the water is able to transgress the cellular membrane and go in and out of cells, right? So the diffusion distance increases. As the diffusion distance increases, you can see the histogram shifts to the right, okay? And there's a cartoon there just showing you that effect. Now, look at the same patient. So we're just going to follow this patient on her journey. And you'll see how we were able to see a new metastasis that appeared here that we got rid of with RF ablation. Then she had a new metastasis over here, and we got rid of that one by an RF ablation. And you can see at this point, which is about a year later, she's now beginning to develop new bone disease, right? Can you see what we've been doing? We're monitoring disease and saying something's worse, get rid of little spots. You know, it's spot welding. But what do we do about the bone marrow? We can't spot weld a bone marrow, right? That's an issue. Now, the interesting thing that you should be asking yourself is, what happened to the ADC across time in this particular bone marrow? And this is some Siemens software that we've been developing with Siemens. And you can see, for example, here is the muscle normalized signal intensity. In other words, this is a tumor to background ratio of the signal. Okay, and you'll see across time that the signal intensity decreases, which basically follows your eye. You can see the signal intensity steadily decreases over about a year, which is you've been able to quantify. Now, look what happens to the ADC. You'll see how the ADC moves to the right, which is what you were able to see before, but then it starts to come back. You'll see how the ADC went up and then begins to come down. Now, what you've now got is a single voxel that has a signal intensity that has biological meaning, but also has an ADC value. And you can cross-triangulate that. Okay? And what you see there is the spread of the pixels. In this particular instance, what I've done is taken the pelvis and then matched it on all the subsequent examinations. So I've matched the bony pelvis across 5 time points with registration. And you'll see on this axis, I've got the signal intensity. Here I've got the ADC. And you can see that the cloud, which sits over here, moves to the top, moves to the left, and then begins to fill this box. Can you see that? More and more over time. So this is an intriguing observation. It's consistent, and I'll show you other examples in a second. So why does it actually end up in that box? In other words, why do you get a lower ADC, and why do you get a lower signal intensity? Okay. Now, of course, what you can do is look at another component. Okay. So another biomarker, and there's a beer called polygamy, and in Utah, and it says, why just have only one, right? So that's exactly right. So you've already got 2 biomarkers. Let's look for a third that may explain that change. And by looking at the fat fraction, for example, that could be the explanator. So look what happens to the percentage fat fraction. It's low to start with. Tumor cells get rid of fat. As you kill tumor cells, the fat comes back, correct? And look what happens at the end of treatment. The fat is back. And the fat lowers the signal intensity and lowers the ADC value. Now, of course, now you can able to triangulate each voxel. Okay? So here's the fat fraction increasing over time. So this is a quantitative measure of fat within the bone marrow. And of course, what you can then do is triangulate every pixel by its signal intensity, by its ADC, and by its fat fraction. Okay? And of course, that isn't all. You could put other parameters onto that. You could put a parameter that reflects the bone density, for example. That's what's meant by multiparametric imaging. And you can see how, over time, the signal intensity, the ADC goes up, the signal intensity comes down, and eventually, as the fat repopulates, the fat moves forward. So the fat fraction moves forward across time. So this is this multiparametric concept that I'm alluding to across time. Now, what you can then do is to say, okay, now I seem to understand what these are telling me about what is normal, what is abnormal, what is kill, and what is repair. Right? Repair is what we are now beginning to incorporate into this. So it's not only about kill, but it's about repair. So here is the same concept explained to you in a stylized form. So we know, those clouds were showing you that this is where the active range is, and you can do the experiment to find that out. You'll know that active tumor is here. As you kill, it goes up with chemotherapy. Then it comes down. but intriguingly never ever goes into this lower left box, which is where normal marrow resides. In fact, I have never seen normal marrow come back in its entirety into this left lower box. And I'll show you some examples of that in a second. Now, so that's what seems to happen with dramatic cell kill. Now, sometimes you get this pattern, and maybe you didn't see that, but it goes straight across in that direction, okay? And here's an example of that phenomenon. So here's the cell kill with chemotherapy here, but look what happens to this patient. You can see the signal intensity again goes down, but the ADC change is not as dramatic. So here is the same line. This is the 1500 micrometers per squared per second line. You'll see that the majority of the pixels with chemotherapy move across that line. In this particular instance, only a minority of pixels, pre and post, move across that line. So what's the difference? Right? What's the difference? Well, it seems to be the way that cells are killed. So if you have a large amount of cell kill, chemo, radiation, indiscriminate, you get an inflammatory response, lots of water, hence the T1 pseudoprogression that I alluded to earlier. But if you have a pro-apoptotic mechanism, where there is organized cell death, then you kill a cell here, another one over here, another one over here, and there's no inflammatory response, then the ADC doesn't go up that much. So suddenly we have a technique that will say the mechanism of cell kill seems to be X as against Y. And then you can start to use that in your experiments to try to work out what is happening in the entire tumor. Do you see what I mean? So you can see the power of these techniques, and what you'll notice is that in different regions, and I'll show you an example, in different regions you've got different mechanisms of cell kill in the body. Now, let me just show you another example. So here is a patient that I've done 4 times, and you can see that the signal intensity reduces over time. This is a lymph node here in the pelvis that also disappears. Patient gets better, but clearly not cured, right? Hormonal therapy never cured anybody, never. It keeps a check on things for about a year, right? And look at the dates. December, July. Actually, not even a year. Because you can see by December, the tumor's already coming back. And how do I know? All you have to do is look at the red arrows. Look at the retroperitoneal lymph nodes. So the bone marrow got better. About a year later, things are going to get worse. And if you don't intervene now, in 6 months' time, she is going to be in a lot of trouble. So you've got a very early signature that says this patient's going to get worse. You need to act now, not later when she is full of metastatic disease. That'll be a disaster. Now, if you were to do conventional images, the radiologist would say, Bashir, no change, no change, no change. T2, no change, no change, no change, right? So conventionally, you'd say no change, no change, no change. Can I have $1,000 for each exam, right? So you'll make the money. But what benefit was there for the patient, right? You clearly know from the diffusion that she got better, then she got worse. Right, so let's just look at the histogram analysis in this particular patient. You'll see I was talking about the clouds. The clouds are over here. This is, again, that Siemens software that I was talking to you about. Well, look what happens. It goes straight across into this box. You'll notice it doesn't fill this box, which is the normal area. And then, as she gets worse, you begin to repopulate this box. So you can see the shift of the cloud, and that, I said to you, wasn't much of an ADC rise, right? It went straight across, and now it's coming back. So you can begin to follow what's happening at a voxel level in a bone over 1 year. That's incredibly powerful in terms of trying to work out what's happening to patients. Now, if you shrink the extracellular space, for example, with an anti-angiogenic drug, then all bets are off, because funny things begin to happen. If you shrink the extracellular space and you don't kill the tumor cells, then the ADC could go down because the extracellular space is less. So an anti-angiogenic drug will cause the ADC values to go down. So look at this patient here that I showed you before. Here is the patient before cabozantinib. Cabozantinib targets VEGF, vascular endothelial growth factor, and the c-Met inhibitor. Okay, so look at this bone scan 1 and bone scan 2 after 12 weeks. Normalized. Patient cured? No. Before? 12 weeks. So in the old days, you'd say complete response, this is a triumph, right? Crap. It's not true. The tumor is very much alive. Okay. The bone scan is telling you something, but it isn't telling you the whole story. Now, look at the diffusion scan. Okay, look at the bone, look at the ribs, for example, before and after. So signal intensity went down. Hang on, there is something happening here, right? Okay, but look at these adrenal glands. So these are metastatic deposits in the adrenal gland before and after, before and after. So lots of tumor there, still very alive. Okay, look at these lymph nodes in the retroperitoneum, before and after, not much change. Okay, so let's look at those clouds we were looking at. Okay, now we know from some recent data that's just been published, and this is a paper that just appeared a couple of months ago, that if you see that bone scan change, it does actually correlate with stuff that matters in the clinic, particularly pain. So if you look at pain scores, they go down, narcotics use goes down, this progression-free survival is a little bit better at 6 months. Now, so we know that there's something happening with this drug. The question is this patient going to live longer? I can tell you, if you took this patient off the treatment, they'd be dead in a month. It seems to cause some sort of switch in patients that if you take the brake off, right, they rapidly accelerate, and I've seen a number of patients like this die very quickly. So it's doing something, but it's transforming the tumor. Now, let's just look at the diffusion map again. So at those clouds we were talking about. So here we are, the baseline scan. This is after 13 weeks. And what you'll notice is that it's gone straight across. Can you see over there? So the cloud went straight to the left, okay, which is consistent with a pro-apoptotic mechanism, right, which is what we were saying, but the ADC may have been hindered. Why? Because of the anti-angiogenic effect. So it could have gone this way, but because you dehydrated the extracellular space, it didn't go up that high. So here's a project for somebody, one of you, to go and do, right? What is the difference? Why are we seeing these different patterns? What does it mean biologically? What is the exact mechanism? Yeah? Number of projects one can do in this area. Now, so we've seen these journeys through the clouds, correct? Clouds moving across the sky. We can see clouds moving on our computers. Now, this is what I've just described to you. Things getting down and better. And of course, that doesn't happen in real life. In real life, what happens? Patients get better, then they get worse, then they get better, then they die. So you should be able to capture that, correct? And you can. This is what you would expect to see, right? And that's exactly what happens. So here's a patient that I've done 12 times, 10 times. So you can see I did this just last week. We started off in 2011. We're now in 2013. And what was the average age? How long are the people going to live on average? We said 2 to 3 years. So you can see she's pretty close to the end of her journey. Okay. Now let's just look at the diffusion weighted scans initially. So they tried hormonal therapy. Didn't work. Right? Okay. Now, what they didn't do is wait till she was like this before changing. They said, this doesn't work, right? They switched. They gave her chemo. They gave her chemo, and look, it worked. But you can't give chemo forever, right? You stop the chemo, and then what happens? Tumors get worse. And look, it got worse. And this is the next exam, got worse. Then they panicked and thought, oh my God, we need to do something. Remember, she's completely asymptomatic. Yes? This whole time, she's completely asymptomatic. Then they thought, let's try another hormone, right? This one didn't work. Let's try a different hormone. They gave her Megace. And look what happens. She just gets worse and worse, right? And I'm ringing the bells, calling the physician, saying, what the hell are you guys doing? This girl's getting worse. He said, but she's feeling fine. I said, I know she's feeling fine, but you know the volume of tumor in this has tripled while you're watching this, right? So then they give her second-line chemo, or in this particular case, it's actually, Vinarelb is actually a third-line chemo. But anyway, what happens after this, you see? They've given her 3 cycles of chemo, and she's not any better. So I'm saying, look, this doesn't look like it's working. They'll go, she still feels fine. I'm going to carry on, they say. All right? I said, fine. And look what happens. She develops a cholecystitis. So she's got a gallbladder inflammation, which is that big black spot there. So that's a bag of pus in her gallbladder. But look what happens to her bone marrow. It's got better. Then I'm ringing the phone saying, the good news is she's responded. And it's actually true. The clinicians know that sometimes you get these delayed responses. So you just press on, right? And that's what you can see. But I said, the bad news is the patient's got an infection, right? Needs to see a surgeon now. That's a big bag of pus there. She's going to die of that, not her tumor, right? Now, so you can see this is a journey that's lasted over 2 years that we've been able to monitor very carefully and titrate her treatment to try to slow this process down. Now, let's look at the journey through the clouds that we were talking about. So you can see initially most of her voxels are in this box over here. Then she gets worse with hormonal therapy, which as you can see over here. Then they switched to chemo, and we said chemo would cause the ADC to rise and signal intensity to reduce. So you can see that there, right? But look, she never fills this box, right? She never fills that box. So you can predict that this patient isn't going to respond very well. And look what happens, right? She fills this box. So they've stopped the chemo, right? And instead of it heading into this heal zone, actually it comes back into this zone, which is the active tumor zone. And that's her next. This is when they panicked again. Then this is when they gave her second-line hormones. You'll see, didn't do a thing. Then they switched her to the next chemo. After 3 cycles, nothing. And after 6 cycles, it begins to change again. So what we're saying is this is actually a very powerful technique that you can use to monitor response in a very careful way, and you can get an idea of the proportion of tumor that's been segmented that is in the alive and in the dead zone. So you can now begin to say something quite intelligent to your clinician. You can say approximately X% of the tumor that we have segmented, and in this particular case it was the lumbar spine in the pelvis. You'll say, in these areas it looks like 80% is alive, 50% is dead. You see, that's actually quite powerful in terms of trying to titrate patients' treatment. And this, I think, is really shown very well in this particular example. So this example, you'll see this patient has multiple myeloma. So she gets treated with a chemotherapy, which is doxorubicin, and bortezomib, which is a proteasome inhibitor. Okay, now look what happens. Signal intensity goes down, but look at all these black spots. All these black spots represents residual active disease. So I'm ringing the clinician and saying, this isn't a great response. Yeah, she's a bit better, but you need to do something else, right? So they don't do anything. She's feeling fine, and then she's like this. So now she has myeloma cells or blast cells in her peripheral blood. It's not only in the bone marrow, it's everywhere, right? Then they think, we need to do something, so they can give a very strong chemo. So one of these chemos is called ESHAP, right? Now, normally you give one dose, and it obliterates the entire bone marrow. This is what they do before they give you a bone marrow transplant. They either give you one dose or they give you 2 doses. Most of the time, just give you 1 dose. So the clinician said, I want to know if this drug is working. And you can see this is after 1 cycle. Look at the dates. 1 cycle. So I say, hang on, this is a really good response. This is fabulous. So I ring up the clinician and say, this is a good response. And she says, okay, I'm going to give her another one. Okay, and look what happens. Bang and bang. So now I ring up and say, a further response, but you still stuff left there. You haven't killed it all, right? She says, I can only give 2 doses. That's it. If I give her another one, I'll kill her, right? And look what happens on the follow-up scan. So this is going to be a tragedy. You know this is going to end badly, right? And that's what's happening on the other side of the street. So you can follow the clouds. You can follow the clouds in this particular instance. So you can see, as I said to you, everything is in the active range, and it shifts to the left. Good response, but look what happens. It comes right back. You give her the first ESHAP, and it's going in the right direction. Then it ends up over here, which is what you expect and what you're able to see, and you can quantify that now. But you can see now she's ready for the next medication, if there is one, right? So why have I gone through this explanation? So the current paradigm, which is what I was saying to you, or the old paradigm, you use serum markers which don't work very well, bone scans which suck, CT scans that don't work very well, and this is how we're treating patients today, right? What you guys need to do is to develop technologies and techniques that breaks this categorization, right? If you were able to do this, then you would change medicine. You would change medicine because you break a fundamental paradigm, right? So, for example, if you can break this category into response, stable, and progression, from progression, no progression, to response, stable, and progression, it's a simple paradigm you need to change. You change everything. How patients are treated in the clinic. And remember, we're talking about prostate, breast, and myeloma. So in the USA, we're talking about how many, Bashir? How many deaths? 250,000 altogether? Just from those diseases. 250,000 people. And that's all you need to do, right? It's tough, right? It's all you need to do. It's going to be tough, right? So what are these new, what do you need to do? Well, you need to work in this area here. This is where the science needs to develop. You need to do circulating tumor cells. That's been done, right? But you guys need to look at circulating DNA, whatever, right? That's what you need to do. But don't forget that there's going to have to be imaging in that. And one of these is diffusion imaging, but it could be a bunch of other stuff, right? It could be PET probes, it could be anything. But this is what you need to do. Make that change, make it happen, and you suddenly change how patients are treated. If you change the way the patients are treated, then maybe with new drugs, you change how people survive. Okay, so clearly there are challenges, not only for you and from a discovery perspective, but from us, from the delivery perspective. So one of our biggest problems is that we have too many tests, right? We have too many tests. There's a whole bunch of panel of tests, and then from that we have to decide what we're going to use in the clinic, and that is a problem. The second thing is heterogeneity, and I've illustrated spatial heterogeneity to you a few minutes ago. But heterogeneity occurs at several levels within the same lesion, between lesions in the same patient, and across patients, but also across time. So there's 4 dimensions, at least, of heterogeneity. So here's an example of a patient that I did twice, July to September. And you can see that the tumor volume increased, right? But if you look at the nodal and the soft tissue volume, that actually went down. So you can see the metastasis volume went down. Yes, halved. The ADC maps went all over the place. Some of it got better, some of it got worse. So as an example, an illustrative example of what is happening in the clinic, right? It's not like a rat tumor, right? There are 4 types of prostate cancers in rats that have been cloned, 6 types. That's it. It's not like that. Yeah? Every single clone is different. You can have the same patient with 3 different cancers, all going on at the same time. Right? The heterogeneity in the clinic is tremendous. We need to, and this is where I think you can really help, is to understand the biology behind the image. When we make these observations, or when you make your own observations, what is the biological underpinning for those changes that are observed, and how can we then exploit that in terms of a patient benefit, or in working out a mechanism of how the drug works, or whatever. Okay, that you need to do. Now, Bashir and I, in particular, need to work on common measurement methodologies. In other words, his technique needs to be the same as my technique. And that has to be the same as the technique that they use in Memorial Sloan Kettering or at MD Anderson. The problem is, the way the system is set up is that we compete with each other. And when we compete with each other, we know Bashir will say his technique is better than mine. And that's, of course, that is a problem because, we're fighting on the technique front, never mind what it can be used for. We need to get beyond this, and, and there have been a number of consensus documents that are being published in things like DCMRI and on diffusion, but we need to increase this in PET and everything like that. So that really needs to be nailed. And of course, what we need is for you to provide you with what are known as roadmaps. So we need to provide you with a roadmap so you can say, okay, I'm interested in this particular technique. I want to know how far it's been developed and where it needs to go next. Right? So those are roadmaps. And the NIH is beginning to produce roadmaps so you can take any given technology that's your favorite and say, okay, I think it's at this stage. So what I need to do next is this, 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 and this, if I'm going to put it in the clinic. Right? You need a recipe. These recipes are now being developed. Okay, so the take-home point is that personalized medicine is not here. We're not at the level of personalized medicine. We are at the point of precision medicine. We are just getting to that point. And within that paradigm, multi-parametric imaging will be there. So the work you do is important. Imaging is going to be important because of the strengths that you already know. It's multispatial, it's multispectral, and it's temporally resolved. And nothing else does it. I mean, you've seen this stuff. Nothing else does it. No blood test is going to tell you that your big toe is better and your brain is worse, right? No blood test is going to tell you that. The only thing that'll do it is imaging, okay? Clearly, we need frameworks for development so that we can take these new therapies and our own techniques into the clinic so that we can further this personalized medicine agenda, okay? But the most important thing I'd say to you, well, one of the most important things is to engage with radiologists who are interested in doing what you do, right? Because if you don't talk to your radiologists or you bypass them, then whatever you do in 20 years will never get into the clinic, right? And that'll be a wasted effort. Thanks very much indeed.
All right. Thank you, Anwar. It was a fantastic lecture and overview. This clearly is a new territory for MRI, the bone marrow, a very complex organ. And we have time for maybe one quick question from the audience. Are there any questions for Dr. Padhani about his approach, technique? Okay, I can ask you a very quick question. We're going to talk more in the afternoon. Do you think, because you have so many parameters looking at Dixon, the fat content, the water content, the ADC, the signal at high B, do you think there's a role for a scoring system like we do for, let's say, liver cancer or breast cancer? Because there's so many, there may be discordances between the different approaches. So do you think there's eventually a future for that?
That's a great question. I mean, at the moment, we're developing the science. But eventually, we have to put it in the clinic. And when we put it into the clinic, we are going to have to let radiologists free on this stuff. And, radiologists are the brightest people in the world. So, and we've seen this in other areas. So what we're going to have to do is make it simple. So we'll develop the science with the more complex mathematical approaches, validate it, and then prune it back and say, okay, this is what could be used in the clinic. So I think we'll get there, but I don't think we're anywhere near starting that process.
Okay, very good. Thank you very much, Anwar. Indeed, thank you very much.